Hi there, this is Ben with HCO Thrive, and today I'm back with another provider news roundup. First, we'll cover hospitals/systems and just overall things going on in the healthcare system, followed by skilled nursing facilities and then home health agencies. General themes include sort of mixed news on provider financial health, especially for hospitals. There's also a variety of regulatory and legislative proposals. Then, of course, as always, there's long-term care staffing concerns. The first article I want to discuss is really just a note in Becker's Hospital Review, and this is regarding recent BLS release of job numbers. Title headline is 82,000 jobs in January. Specifically, healthcare added 81,900 jobs. Ambulatory healthcare service added 50,300, while hospitals added 18,300. Finally, nursing and residential care facilities added 13,300. Contrast those numbers to the overall jobs for January, which was 130,000, so you can see healthcare makes up well over half of all new jobs from January. The next article is also from Becker's Hospital Review. This one's titled Reasons for Optimism in Hospital Finances, and this is summarizing Strata's monthly healthcare industry financial benchmarks reports, and that looks at both revenue and then margins and is based on a sample of nearly 2,000 hospitals. First point was that revenue strengthened overall last year. Gross revenue was up 11% in December, and outpatient revenue increased yearly at 13%. Inpatient revenue also rose nearly 8% in December, and overall revenue is growing faster than expenses. While hospital expenses increased 7% year over year in December, total expenses per adjusted discharge declined 4% from November to December. So you're going to have to see if that trend holds true going forward. Labor expenses per adjusted discharge dropped 0.4% year over year, and 5% month over month. Net patient service revenue per adjusted discharge increasing nearly 2% year over year. Inpatient admissions rose overall 4% year over year, and outpatient visits increased over 7%. Observation visits declined slightly, and emergency visits dropped 4%. Hospital operating margins increased nearly 5 percentage points month over month and 1 percentage point year over year. Along similar lines, we have a flash report from Kaufman and Hall regarding December 2025 data. Key takeaways are that margins are stronger than previous years. Patient volumes continue to grow across all services, but the gap between gross and net operating revenue, alongside a rise in bad debt and charity care, is one of the negative aspects. This is theorized to be from likely a higher proportion of government versus private payers and more uninsured patients. Unfortunately, the latter point is unlikely to improve given the lack of or the ending of the stipends for the ACA. Next, we have a report from Chartis called 2026 Rural Health State of the State, which is basically what is the financial position of many of America's rural hospitals. Spoiler alert, it's not great. More than 40% of all rural hospitals operate in the red. In the 10 states that did not expand Medicaid under ACA, half of the facilities operate at a loss. Continuing on, more than 200 rural hospitals have closed or converted to models that exclude inpatient care. So an example is a rural emergency hospital. This is since 2010. 417 rural hospitals are vulnerable to closure, including 36% of hospitals in non-expansion states. More than 300 hospitals have eliminated OB services and general surgery, while more than 400 facilities have eliminated chemotherapy. And underlying cuts to Medicaid will negatively impact rural hospitals. Despite the fact that subsidy talks for extensions of the ACA are pretty much dead, CMS has proposed some changes for 2027. This article is from Becker's Hospital Review again, But down below are some links to the sources of these proposed changes. Taking a look, there's 7 different aspects. The first is plan design flexibility. Multi-year plans with terms up to 10 years, 10 consecutive years. Payers need to demonstrate that a sufficient range of providers accept the plan's benefit amount as payment in full. And this is heralded as a way to promote price transparency and competition while eliminating administrative overhead. And it also proposes ending the requirement that payers offer standardized plan options. Number 2, reintroduce program integrity measures. So this would revive previous policies from last year. Exchanges would verify special enrollment period eligibility for at least 75% of new special enrollment period enrollments. Consumers are required to submit documentation proving their household income is under 100% of the federal poverty line. Number 3, subsidy eligibility restrictions. Pretty much only U.S. citizens, legal permanent residents, Cuban Haitian entrants, and then COFA migrants qualify for premium tax credits. Refugees, asylum recipients, and individuals with other lawful immigration statuses would lose eligibility. Number 4, state authority and network standards. States would be required to ensure sufficient provider choice under broader standards. Number 5, payer accountability and enforcement. CMS is looking to expand regulations on marketing practices, and this includes practices that are illegal, such as cash incentives to enroll, false claims of $0 insurance, miscommunication of enrollment timelines, basically things that are pretty much fraud. Number 6 is essential benefits and maximum loss ratio changes. This would remove adult dental essential health benefits, with the idea that this better aligns with the standard typical employer plan. And then finally, CMS is also seeking comment on whether to adjust the federal medical loss ratio rule in the individual market. And this could affect the 80-20 rule, which stipulates that only 20% of the money that insurers take in can be used or kept as profits, spent on marketing and other things like that, whereas 80% has to go to quality improvement and paying out beneficiaries. And then finally, we have financial parameters. Number 7, CMS would update its risk adjustment models with more recent claims and keep the user fee flat at 20 cents per member per month. And lastly, payers would get more flexibility in quality areas to focus on, with CMS dropping requirement to address health disparities. One thing to keep in mind is that what I've just presented is still just a subset of all the possible rule changes. So I would recommend taking a look at the original sources if you want to really get a full idea of what's being proposed. Our final hospital article is from Becker's Clinical Leadership, which basically summarizes a study in JAMA Open. This is about what factors would get bedside nurses to return to the workforce. Bedside nurses being someone who's actively involved in patients, ICU, ER, etc. Some of the key points up front are that a majority of nurses who left the bedside roles in recent years are willing to return if conditions are adequate. And specifically, they mentioned adequate staffing as the main factor that would reattract them. And this is over things like pay, benefits, and a flexible work schedule. And the survey was based on over 4,000 nurses who left the position between 2019 and 2023 and are not currently working in healthcare. Some more. Among nurses who were unemployed, 51% of unemployed nurses searched for healthcare jobs within the past year and reported being likely to return to nursing. Adequate staffing was the top selected response, 65%. This is overall. But across age ranges, at no point was this surpassed by anything else. And then, of course, followed equally by flexible scheduling and better wages. Nearly 40% left their positions earlier than they had planned, even though 90% reported being satisfied with nursing as a career. And this disconnect indicates premature workforce exits are largely driven by modifiable organizational factors, which of course is staffing. And just taking a quick look at the article, this is open to the public, so you can check it out if you're interested. This just covers the methods. And here you can see some of the tables. This is demographics and employment experiences. And these are the organizational factors that would increase their likelihood to return. And with there being so many nursing shortages all over, it would behoove organizations to pay a little bit of attention to this. So if you're interested, go ahead and check out this article. Moving now to skilled nursing facilities. Well, technically this next article sort of bridges between hospitals and nursing facilities, but I grouped it in the latter. And the long and short of it is federal 3-day rule for nursing home coverage backfiring. And this is based on another JAMA article, which I don't have access to yet. And I found this summary in McKnight's long-term care news. And the summary is investigators found that reinstating the 3-day rule after pandemic suspension resulted in longer stays without improving outcomes or lowering SNF use. The rule is causing unnecessarily long hospital stays and delaying nursing care, and hospital stays are lengthened to meet Medicare's nursing home coverage threshold, which results in more costs to hospitals while failing to reduce Medicare outlays. And just in case you're not familiar, the 3-day rule requires a Medicare patient to spend 3 days in the hospital before they will be covered for subsequent skilled nursing facility use. And some more information. Hospital stays of 3+ days by Medicare patients rose by 1.1% after the rule was reinstated, and 5.6% among those who rehabbed at nursing homes. And basically the premise of the study was that this rule was shut down or suspended during COVID and then reinstated, so that the authors attempted to use this as an opportunity, sort of a natural experiment. And this amounts to more than 2,000 extra hospital days during the first month after reinstatement alone. This 3-day rule was introduced 60 years ago to moderate costs for hospital patients needing nursing home care. Hospital stays were close to 2 weeks when the 3-day rule was enacted in 1965. But previous reform efforts have been hindered by uncertainty about the effects of expanding SNF coverage. So 2 weeks is a long time compared to now, which I think is just a couple of days. So you can see that this rule may need some adjustment. This article is just some evidence. I would suggest that it needs more. I also wasn't able to review the article personally other than the abstract, based on the fact that even through institutional access, it's too new. So maybe at some point in the near future can take a look at it. But you can see here, JAMA Internal Medicine, and at least you get some of the information in terms of the results, but not the full article. Next article is also from McKnight's Long-Term Care News. This is Congress moves to institute its own long-term care staffing rule, force more spending on the workforce. The Senate bill would require an HHS study within 2 years of enactment and then every 4 years. These studies would address the question, are staffing levels sufficient to meet resident needs? And they would need to include the voices of residents, families, frontline worker, nursing home operators, unions, etc. Just to be clear, this is only a proposed legislation at this point, but it's something to keep your eye on. As you might expect, nursing homes and those who represent them are not exactly thrilled with this idea, based on that it's quite difficult to find staffing and that they operate in a quite challenging environment. So here's a quote. "It's unfortunate that a minority of lawmakers are focused on outdated and failed policies of the past rather than common sense and forward-thinking solutions. Nursing homes have made significant strides recently, but to address our nation's growing caregiver shortage, we need a collective effort in Washington to help us build the caregivers for tomorrow. We stand ready to work with policymakers from both parties on better ways to strengthen the nursing home workforce and quality of care." And that's from Cliff Porter, President and CEO of American Healthcare Association, National Center for Assisted Living. And the next article is also from McKnight's, and it's another attempt to try and address workforce shortage issues. CMS reignites $80 million long-term care nurse education grants program. So this actually existed last year, but no funds were dispersed. Last fall, CMS said the program was being tweaked and would restart it in 2026. It attempts to tackle severe shortages of government facility inspectors, as well as help bolstering the facility workforce. Includes stipends and loan repayments to RNs and LPNs, assuming they work in a federally qualified nursing home or state survey agency. This next article is yet another one from McKnight's Long-Term Care. Providers may be blindsided by unexpected CMS antipsychotic data changes, experts warn. Updated long-stay antipsychotic measure now includes Medicare and Medicaid claims data and Medicare Advantage encounter data to supplement the MDS data. Prior to the update, the national average for long-stay antipsychotic measures was 14.423%. However, after this new data sources were added, it's jumped to 16.69%. And this means that most providers will experience an increase in percentage points. The good news, however, is that the methodology remains for calculating the star ratings remains the same. Providers are separated into deciles. So if everyone's points jump, there's no real danger of a provider perhaps having a lower star rating unless the data from the claims and Medicare Advantage really conflicts with previous MDS data. Now we move to home health news. This article is from McKnight's Home Care. However, I've seen a similar article as this multiple times, multiple places over the past few months, and basically it's expressing that the administration's immigration policies may have a deleterious effect on caregivers, specifically limitations on the H-1B visas. So more specifically, new and continuing H-1B visas for healthcare and social assistance increased by over 8% from 2022 to 2025. And that includes visas for workers of home health agencies, hospitals, nursing homes, etc. Policy changes that are expected to reduce the number of H-1B workers include the $100,000 entry fee, which is still, I think it's being challenged in court, enhanced vetting, and then online presence reviews. But ultimately, we'll just have to see what policies stick and what the result on home health and other workforce is. And our final article for the video is another from McKnight's Home Care, and it's titled Hawley Warren Introduced Bill to Break Up Big Medicine. A new bill may have implications for so-called payviders, insurance companies that also own home health agencies. Senators Warren, Democrat, Massachusetts, and Hawley, Republican, Missouri, introduced Break Up Big Medicine Act. You can see it's a bipartisan effort, so people are actually agreeing on something. Prohibits healthcare entities from simultaneously setting prices and providing healthcare services while also paying for those services. And more specifics about the sort of vertical integration that they're attempting to target. Vertical integration allows one company to control every part of the supply chain. So example, physicians' practices, pharmacy benefit managers, and insurance companies. The idea then is that these conglomerates steer business to their own subsidiaries, and this ultimately leads into an increase of government payouts. So this bill prohibits a parent company from owning a medical provider or management service company and owning an insurance company or prescription benefit management firm. And that's it for today's roundup. Please let us know if you have any questions, comments, or feedback. I'll try to remember to put the sources in the description, and thank you for watching.